Hello everyone. Today again I'm going to talk about the glomerular diseases in detail. Before that, just a brief recap about what we have discussed yesterday. So I have discussed about the introduction of the kidney. Okay, what is the kidney for? It is basically an excretory organ, and then it is trying to help us to eliminate the unwanted material, and then it is also helping to maintain the acid base and the electrolyte balance of the body. It is a wonderful organ that God has created, that whatever you take in, whether it is a juice, milk or wine, whatever you take, it gets converted into urine, right? So we spoke about the kidney structure. Essentially, the kidney is a reniform shaped organ. The adult kidney has a smooth surface and is having a capsule, and then it is invested in the, because it is a retroperitoneal organ, it is invested in the fat, and then it is having lot of protection or cushioning around the kidney, and it is also having geratospacia. Okay, and then almost like the weight is like 125 to 170 grams. The kidney weighs such in the adult. The female and male little difference will be there regarding the kidney size. Okay, now coming to what when you take a hemisection of the kidney, how does a kidney look like? The kidney is having a capsule. I already told you, so you'll be able to identify the capsule. Then you will be identify the cortex, then the medulla, the renal pyramids, the renal calyces, and then the renal sinus, the pelviureteric junction. So these are all the things which you find when you take a hemisection of the kidney. So whenever we are having the problem of identifying a disease just by looking at the gross picture, you need to look firstly about the capsule. If you're trying to strip the capsule, if it is adherent or not, that will give you a clue about any underlying pathology in the kidney. And then the cortex and the medullary ratio will give you an underlying pathology that is associated with the renal disease. Okay, so you can inspect the renal vein to know if there is any thrombosis. That's how the gross, in the gross itself, we can know what kind of disease it is. Then coming to the vasculature, you know that the kidney is drained by the renal vein. The renal vein has to be inspected in the renal cell carcinoma because staging gets different. Then the renal artery is the one which arises from the aorta and supplies the kidney. The renal artery gives rise to anterior division and the posterior division. The anterior division is again divided into the segmental divisions, which are again divided 5 segmental divisions. Both the anterior and posterior division get divided into, and these segmental divisions will again divide into the interlobar divisions, and then they form the arcuate arteries, then the interlobular arteries. So these are the things which are trying to supply the kidney. What compliance the patient will come to you when the patient is having any kind of a renal problem? When do you suspect a patient to have a renal problem? Is that the person comes to you with a fever, then you inspect for all other things, then you're not you give a complete urine examination, you find pustules, then you can suspect it as a urinary tract infection. The urinary tract infection can lie in the bladder or the ureter or the kidney itself. Okay, so there can be a chronic pyelonephritis or acute pyelonephritis or any kind of urinary bladder infection called as cystitis. So the patient can come with fever, the patient can come with thirst or polyuria because of imbalance between the fluid and electrolytes. Then there can be metabolic acidosis regarding the acid-base balance, and then there can be fluid retention which can lead to pulmonary edema, or it can lead to overall body edema or anesaka or puffiness of the face, then swollen ankles. All these are the result of the fluid retention in the body. So again, there can be in different metabolism of the calcium, because the vitamin D is essential for the calcium metabolism, which is being formed in the kidney by 125 hydroxycholic acid phenol is the thing which is formed, which we call as activated form of the vitamin D, that it helps in the bone mineralization and all. So that won't happen if the kidney is not functioning properly. It also helps in the production of RBC by releasing the erythropoietin, and then the patient may complain of anemia. Then kidney also helps in the formation of or regulation of the blood pressure, because the blood pressure is regulated by a main mechanism by renin. You know that the renin will how it secretes, how it constricts the efferent arterioles and dilates the afferent arterioles. Then it is released by the juxtaglomerular cells, which we have already discussed in the last class. So these are the clinical manifestations of the renal injury. So what are the symptoms and signs the person comes with when he has a renal injury? First thing I told you, you have to know about what is azotemia. Azotemia is increased blood urea nitrogen and creatinine and decrease in the GFR. So what happens is that there is the signs of uremia and then azotemia. So because of that, what happens? The patient may complain of itching, the patient may have some disorders or biochemical abnormalities which can lead us to the renal pathology. So this azotemia can be caused by pre-renal, renal or post-renal. Okay, pre-renal, the hypoperfusion of the renal, and then the renal pathology wherein the GFR is diminished by itself because of underlying disease, a tumor or anything which is infecting or inflamming the glomerulus and interstitium of the tubules. Then we have spoken about the post-renal because of an obstruction by the tumor or the stone, which will cause the difference in the blood urea nitrogen and diminished GFR. So after azotemia, there can be uremia because the product of the ammonia, which has to be urea and ammonia, which has to be secreted, are not being secreted efficiently. So because of that, there will be accumulation in the blood. So this will lead to uremia. This can cause uremic fibrinous, pericarditis, gastroenteritis. Okay, so these are the things which can happen when there is unwanted toxic material. So that there can be some asymptomatic lesions, wherein the asymptomatic lesions may just have mild form of the disease, that is asymptomatic hematuria or something like that. So again, you have to know something called as acute kidney injury that can happen from hours to days. Okay, this is in similar with the rapidly progressive glomerular nephritis, wherein the deterioration of the renal function is occurring within hours to days. Okay, there is diminished GFR. So just because of the GFR, we can know that there is an underlying renal pathology which is just deteriorating very rapidly. Then we have to know about what is known as the chronic kidney disease. I told you the definition of chronic kidney disease yesterday, that it is less than 60 ml GFR per minute per 1.73 meters square, persistently present for 3 months or so. So when you are looking at the chronic kidney disease, that means that there is already diminished GFR and then there is just progression to the end-stage renal disease. It can't revert back, but then you can just maintain the GFR in chronic kidney disease. We also spoke about the acute glomerular nephritis, which is characterized by hematuria, dysmorphic abscesses that can be seen in the complete urine, the renal microscopy, urine microscopy. So the acute glomerular nephritis can be known by hematuria and oliguria, which can be seen. I have already given you the definition of oliguria, which is less than 400 ml per 24 hours. Okay, and then when we speak about acute glomerular nephritis, we have to know that the proteinuria is occurring. we have to know what kind of proteinuria is occurring. So the proteinuria usually is defined by more than 150 uh, milligrams per 24 hours, right? So when more than 150 milligrams per 24 hours is excreted out, it is called as proteinuria. Okay, and this can be seen in glomerular nephritis, that is any kind of nephritic syndrome or nephrotic syndrome. You know, in nephrotic syndrome, there is more than 3.5 grams of protein that is being excreted. Okay, so because of that, there will be hypoalbuminemia, lipiduria, hyperlipidemia, and also severe edema. These are the 5 things you have to remember regarding nephrotic syndrome. So I just told you what are the signs and symptoms, that is azotemia, uremia. There can be asymptomatic hematuria or just mild renal pathology. Then it can be acute, rapidly progressing, or it can be chronic, you know, and these things are a part of renal pathology. So in the terminology, you have to know a few things about the urine output, that is polyuria, oliguria, anuria, absence of urine. Oliguria, I told you, polyuria is multiple times you want to be, nocturia and nocturnal urine output. You know, usually the nocturia is present in the tubular disorders or diabetes. Okay, so these are the terminologies which you have to know. Then hematuria can be caused by any kind of stone, tumor, cystitis related to the urinary bladder infection, or it can be related to the uretropelvic junction, or it can be related to the kidney. Okay, and then the proteinuria, I told you, are few types: the functional proteinuria, the overflow proteinuria, selective proteinuria. Okay, the non-selective proteinuria. All these things are important for you to understand the basic renal disorders. So without understanding the terminology, you can't go ahead and know about the various renal disorders. So what are the investigations you look for? The investigations you look for are biochemistry. Obviously, you order a blood urea nitrogen. Okay, the blood urea nitrogen is important, and it can be variable in pre-renal, renal, and post-renal causes, right? And then creatinine. Creatinine, I told you, is a result of the breakdown of creatinine in the muscle, that is usually 0.6 to 1.2 milligrams per deciliter. So this can be seen increased in any renal pathology because the GFR is diminished and it is not able to excrete the unwanted material out. So again, there is the blood urea nitrogen and creatinine ratio, that is usually in normal persons it's 15, and then in pre-renal causes or the post-renal causes it is usually more than 15. But in the renal pathology, it is usually less because the source of the excretion is being taken up by the skin and the gastrointestinal tract, right? So these investigations are related to the biochemistry. Again, you will ask for a CBC to know if there is any infection. You will ask for a complete urine examination to examine the number of cells present in it, whether there are any CAS, whether there are any crystals present in the urine. So because of that, we can get to know about the renal pathology. So again, you should ask for some kind of investigations related to the ultrasound, CT, MRI, and renal ureterogram when you want to know where the disease is being uh, situated in the urinary system. Okay, these are the investigations to be asked for. This is the minor recap. I will be going to deal with the structure of glomerulus and the mechanism and the pathogenesis of glomerular injury now. So this is the loop of Henle, and then you can see, I'm sorry, this is the tuft of the glomerular unit that is having an afferent arteriole and the efferent arteriole. Here you can see this is the Bowman space, and then this is the proximal convoluted tubule and the loop of Henle, the ascending limb and the descending limb. And this is the still convoluted tubule, and this is the collecting tubule. Yesterday we have known, I am just recapping again, because without understanding concept, you can't understand what the diseases are. So here you have, this is a proximal convoluted tubule wherein the maximum absorption, reabsorption of sodium and water occurs here. The bicarbonate ion is getting reabsorbed here. There are some aquaporins which will reabsorb the water here. So again, the descending limb permeable to water, ascending limb permeable to the ions, and the distal convoluted tubule wherein there is the sodium and the chloride co-transportation that is occurring. And here the collecting tubule, it has two cells, I told you, the principal cells and the intercalated cells. The principal cells help in relatively is permeable to water, because whenever there is aldosterone stimulation, there will be reabsorption forming the coalescent of the intracytoplasmic vesicles, then the aquaporin formation that will help in the reabsorption of the water. Here we have the intercalated cells which help in the acid-base balance. So this is about the tubular function in brief in the kidney, right? So here we have what is called as a glomerulus. You know, I told you about this blood supply. There is a collateral vessels or complexity of the vessels here of the vasa recta that are being formed here, which will supply the limb. Then here I told you this is the glomerulus, which is the main place where the filtration occurs. So there is an ultrafiltrate that is produced, which is being sent into the tubules. So usually the glomerular diseases are either the primary glomerulopathies or the systemic diseases with the glomerular involvement, or hereditary disorders related to abnormal glomerular formation that will lead to diseases like Fabry's, thin basement membrane, and Alport. So usually when we call it as, so the basic classification is primary and secondary or hereditary, in fact. So the primary glomerular disease, the kidney is the only predominant organ involved, okay, and in secondary glomerular diseases, it is associated with other systemic disorders like diabetes, amyloidosis, you know, systemic lupus erythematosus, all of those. So coming to the glomerular structure, I wanted to recap about the glomerular structure here by showing you. So here I told you the glomerulus is the tuft of the capillaries invested into two epithelial layers, that is the visceral epithelial layer and the parietal epithelial layer. These capillaries are put together by the mesangial cells and then supported by the mesangial matrix. So this is a mesangial matrix. So here we have what? The first thing how the glomerulus helps in the filtration is that it is having an auto-regulation, we spoke about that, and the tubulo-glomerular feedback and the neurohumoral mechanisms, hormonal mechanisms. So because of these three things, the glomerulus, with the glomerular structure, the filtration is happening or the GFR is being maintained. So what is a primary structure is that? What are the structure that helps in the filtration? The first thing is the fenestrated endothelium. So this endothelium has 70 to 100 nanometers fenestrations, so that there is the passage of those molecules there. Then the second one is the basement membrane. So this is the basement membrane. So here we have the basement membrane. The central part of the basement membrane is the electron dense layer, and then the upper part, inner part, and the outer part are called as laminar area interna and the laminar area externa, which are relatively electron lucent. So this is the structure of the basement membrane. So this basement membrane is formed by alpha 6 alpha chains, alpha 1 to alpha 6, wherein the structure is maintained by a C-terminal end, an N-terminal end, and then there is a triple helical compound here. So because of that, they are put together, you know. And then there is a non-collagenous domain 1, which is very, very important, because this non-collagenous domain 1 is the one which is trying to support the suprastructure of the basement membrane, wherein it can attach to the other glycoproteins. So here we have this basement membrane, right? So this basement membrane, if there are antibodies to this basement membrane, especially to the non-collagenous domain 1, then it is called as antiglomerular basement membrane disease. So from here onwards, listen to me, if you understand the structure, if you understand what is trying to help the glomerular filtration rate, now you get to understand all the pathology which is underlying the glomerular diseases. So that is about the basement membrane. Now we have the visceral epithelial cells. So these visceral epithelial cells are also called as the podocytes. Okay. The visceral epithelial cells have a slit diaphragm. Okay. In the slit diaphragm, I told you there is a nephrin molecule which is trying to bind. This is an extracellular molecule. Okay, it is trying to bind into the intracytoplasmic podosin filament, and then they are supported by actin and CD A2P protein. Okay, so the integrity of this glomerular structure is maintained as such. Okay, so after understanding the structure, we are now going to the mesangial cells. The mesangial cells are similar to the pericytes in the smooth muscles. They get, they kind of produce, they are phagocytic in nature. They produce the cytokines which are efficiently working. Whenever there is a glomerular injury, they kind of proliferate. Okay, so this is about the structure of the glomerulus and how the GFR is maintained. So now coming to the glomerular syndromes. The nephritic syndrome, I told you, hematuria, azotemia, variable proteinuria. Usually in the nephritic range, that is less than 3.5 grams per 24 hours. Oliguria, less than 400 ml per 24 hours. Edema and hypertension. Rapidly progressive glomerular nephritis. Acute nephritis, acute renal failure occurring within hours to days. Nephrotic syndrome, more than 3.5 grams per day. I didn't specifically type the other things because you have to repeat it with me again and again. It is hyperproteinuria, hypoproteinemia or hypoalbuminemia, severe edema, lipiduria, and hyperlipidemia. Right? The chronic renal failure, which starts with azotemia, the damage is already done. It just progresses to uremia and to the renal end-stage renal disease. Finally, where the end-stage renal disease less than 5% of the GFR is just being there. So isolated urinary abnormalities, that is glomerular hematuria or subnephrotic proteinuria. So this is about the glomerular syndromes which are associated with the primary and secondary glomerular diseases. So here we see this is the structure of the visceral epithelium again. This is the basement membrane, the fenestrated epithelium. Here you are seeing. This is the electron microscopy picture. You can see in between the podocytes there is the slit diaphragm. Okay, so I told you this podocyte food process, the nephrin molecules here, integrity of the visceral epithelial layer maintained by this nephrin molecules. Okay, so this is the electron dense layer, the laminar era interna and the externa, the endothelium which is fenestrated. So what is the pathogenesis of the glomerular injury? Whenever there is an injury as such, you scratch, you fell down somewhere, then what happens? Usually there is, the body gives a signal that there is a place to act. So all the soldiers, all the white blood cells, all the soldiers which are there won't try to protect it from further injury. So what happens? There will be hypercellularity. Mesangial cells, I told you, are the phagocytic cells which will help in the phagocytosing of the unwanted material, whether bacteria, virus, or whatever, which is affecting the renal pathology, forming the renal pathology. So there's the mesangial cells and the endothelial cell proliferation and the leukocytes, the WBC, which are the actual soldiers of our body, which will get multiplied in the number and all come aggregate to work for the glomerular injury which has happened. Now, activation of coagulation. So activation of coagulation, how and why it happens still is unclear. Now coming to the formation of crescents, how the crescents are formed in the glomerular. This is not a crescentic moon, okay? It's just that word called crescents, that are that accumulation of epithelial cells in the leukocytes at the site of injury. So usually it follows an immune or inflammatory response, obviously. So this cause what? Because there is an injury, all these things are coming and acting over the injured part. So because of that, there is plasma protein leak. Okay, and activation of coagulation factors as such. So that's the reason why usually in a chronic kidney disease patient, the patient may not actually die with chronic kidney disease, but he may have thrombotic episodes which may lead to myocardial infarction. The person may actually have a heart problem, the cause of his death rather than the kidney injury itself, because it's indirectly acting that way because activation of coagulation factors. So second one, the basement membrane thickening. The first one is hypercellularity, the mechanism of injury. Second one is the basement membrane thickening. How can you identify that first? By light microscopy with pearl iodic acid shift stain. Okay, because of that you can identify whether it is thickened or not. And by electron microscopy, if there are any deposits on that, whenever there is an inflammation or immune injury, there will be inciting agents which get shredded. So that can form a deposit either subepithelially, subendothelially, or in the mesangium or wherever itself. So here we are having these deposits in the form of fibrin, amyloid, or fibroblin. Increased synthesis of protein can be seen in diabetes, so this can thicken the basement membrane. Additional membrane, that is a basement membrane is already there, and there is a formation of another basement membrane over that can be seen in membranoproliferative glomerulonephritis and is called as duplication of the basement membrane. So in the mechanism of glomerular injury, that means the glomerulus, when it's having a pathology or an injury, one, hypercellularity, proliferation of leukocytes and activated cells like mesangium endothelial cells are getting into action. Second one, the basement membrane is getting thickened. The third one we have to know is hyalinosis, that is homogeneous eosinophilic material that is composed of plasma proteins which are insulated out, and they get accumulated. Whenever they are getting more accumulated, then it can have obliteration to the capillary lumen, and this can be a result of the injury, right? Then coming to the other one, hypercellularity, two basement membrane thickening, three hyalinosis, and fourth one is sclerosis, that is deposition of extracellular collagen matrix. So this can be focal, segmental, or diffuse. Okay, so the histological changes now in the glomerular injury can have hypercellularity, basement membrane thickening, hyalinosis, sclerosis, and these can be identified in the renal biopsy as the area involved, that is diffuse, that is completely each and every glomerulus is involved, and segmental when only a part of the glomerulus is involved. Global when the entirety of the individual glomerulus is involved. Focal when there is a fraction of the glomeruli in the kidney are involved. Capillary loop or mesangial, the name itself suggests that. So I will define the glomerular disease as diffuse when I see all the glomeruli possibly present in that kidney getting affected. I will call it as segmental involvement only when I look at one glomeruli at a time and I see that not the whole glomeruli is injured but just a part of it. Now I'll call it global when I look at one glomeruli and complete glomeruli is getting affected. I will call it focal when I look at the whole kidney, then I will see a fraction or a part, something like upper, lower, middle, a focal part of the glomeruli are involved. Okay. So these terminologies are important to understand to know how they have termed the glomerular disease. So coming to the pathogenesis of glomerular injury. The glomerular injury can, see, whenever there is an injury, the body reacts in such a way, it has some defense mechanisms. These defense mechanisms are either cell mediated, antibody mediated, okay? Then I'll tell you first the antibody mediated, okay? The antibody mediated ones can be because of identifying an antigen that is already present in the kidney, okay? Or it can be because of a circulating immune complex, or it can be because of an antigen that is not normally present in the kidney but is being planted there, and then the antibody comes and reacts to it. So in this way, we are having an antigen antibody reaction, okay? So the immune mechanism here is that the first thing, the antibody is trying to go and attach to the antigen which is already present there, or it is planted there, or it is already forming an antigen antibody complex and the complex is circulating in the blood, and then it is coming and inciting an injury in the kidney. So in this way, we have different diseases related to the antibody mediated injury, right? So we'll be discussing that here in this picture. So the deposition of circulating immune complexes, okay, which are already present there. So these can just go, be there subepithelially, okay, or they can be present subendothelially. You know, this is the fenestrated endothelium, this is the epithelial layer, this is the basement membrane, okay. So here they are, these antigen antibody reaction happening here in the subendothelial deposits, and then the mesangial wherein they are present here, okay. And then the in situ binding of antibodies with or without immune complex formation, that is antibody against podocytes, epithelial podocytes. Then the anti-glomerular basement membrane forming the linear immunofluorescence. See, I'll tell you here, this antigen antibody reaction, wherever it is happening, whether in situ or circulating, they will form some deposits. These deposits, if they are highly cationic, they will cross the basement membrane, they will be there in the subepithelial region. If they are neutral, they will be deposited in the mesangium. That means they are not carrying any charge. If they are anionic, they are unable to cross the basement membrane, so they will settle subendothelially. Okay. So these deposits, unlike these antigen antibody circulating complexes, if they identify this podocyte itself, the visceral epithelial cell itself as an antigen, then this antibody reacts to this epithelial podocyte. If it is identifying the glomerular basement membrane, I told you the non-collagenous domain 1 as the antigen itself, then it is forming an antigen antibody reaction here. Okay, so this will lead to linear immunofluorescence when we see under the microscope. Here we will see it as granular immunofluorescence. So just remember that there is in situ antibody binding, circulating immune complexes. In situ can be against the things which are already present, circulating immune complexes which are already circulating, right? This is about pathogenesis of glomerular injury, which will cause either granular immunofluorescence or linear immunofluorescence according to the type of antigen antibody reaction and the place where it is occurring. So here, immune mediated injury, so as such, is antibody mediated in situ immune complex, that is either fixed intrinsic tissue antigens, that is non-collagenous domain 1, phospholipase A2 receptor antigen, that is in membranous glomerulopathy, mesangial antigens, the planted antigens I tell you, which are not normally present but they are getting planted, that is exogenous agents, infectious agents, drugs that get planted in the kidney. And then endogenous agents like the DNA, nuclear proteins, all of that. The circulating immune complex deposition, that is the endogenous antigens or exogenous antigens. They form the complex in the blood itself. They are circulating as antigen antibody complex, and then they are coming and sitting into the kidney. Then the cell-mediated injury and activation of alternate complement pathway. Okay, this is the table which will tell you about different types of immune-mediated injury, antibody, cell-mediated activation of alternate complement pathway. So in situ complexes, these are deposition of antibodies specific or fixed. Okay, these are expressed on podocytes. They have been implicated in membranous nephropathy, already told you. And some antibodies may react in situ with previously planted non-glomerular antigens. Okay, so they are non-glomerular. These planted antigens include what? They are breakdown of apoptotic cells in SLE, bacterial products, endostreptocin of the streptococci, and large aggregated proteins. So what we are saying is that the in situ immune complexes can be directed towards the kidney thing, or they can be planted to something which is not glomerular. Okay, so these non-glomerular things can be a bacterial products, and it can be a apoptotic cells as such in SLE. Now coming to the Heyman model of explanation of the glomerular nephritis. When they have injected some antigen to the rat megalin, this is the megalin antigen, there is a formation of a localized immune complex there to the antibody which is present, which reacts with the M-type phospholipase A2 receptor. So because of that, there is formation of an immune complex, that is the antigen antibody reaction is occurring there. Once this reaction occurs, what happens? They are getting deposited. And where these are getting deposited, subepithelially they are getting deposited, and then this is seen in the membranous membranous nephritis, which is associated with the Heyman model. Okay, so this is primary membranous nephropathy, which can be because of endogenous products, which is unclear the mechanism. The secondary membranous nephropathy can be seen because of drugs and graft-versus-host disease. Okay. Now antibodies to the plant antigens. So antigens that are normally present in the glomerulus, not normally present, but are planted there. In infants, if you feed them with the cow milk, what happens is that these milk antigens which go sit in the basement membrane or the glomerulus, and then they incite or attract the antibodies, and then there can be an antigen antibody reaction happening, and because of that there will be an injury. So this is about it. Now anti-glomerular basement membrane, that is antibody mediated glomerular nephritis, is nothing but the basement membrane is there, that is being identified as an antigen, then antibody is coming and reacting to the basement membrane antigen, usually the non-collagenous domain one, the antigen antibody reaction is taking place, that will form a immune complex that is usually associated with a disease called as Goodpasture disease, where the basement membrane of the alveoli in the lungs are also identified as such, and then we have this Goodpasture disease wherein it is not the tricentric type, the linear pattern of staining which is seen in immunofluorescence in the anti-glomerular basement membrane disease. Okay, this is a useful pattern to identify what kind of diseases it is. So the antigen here I told you is the alpha 3 chain of the type 4 collagen. So now coming to the, we have dealt with the in situ complexes which can be either present as such in the kidney or can be planted there or can be seen with the podocytes or can be seen with the basement membrane, right? So that is the example we have given, the Heyman model, the anti-glomerular basement membrane disease, and then infants cow milk and all we have given as an example of the in situ immune complex formation. So now coming to the other one, that is a circulating immune complex, that is a deposition of circulating immune complex in the glomerulus, initiates a complement on the Fc receptor. So there is leukocyte activation resulting in the glomerular injury. So again, this circulating immune complexes to have been formed, they can be triggering the antigens as such, whether they are endogenous components or exogenous components that are creating this. Okay, so here we have a diagram to represent this is glomerulus. I told you this is a parietal epithelial cell layer, the visceral epithelial cell layer. This is the endothelium. This is the mesangium. Okay, so here we are taking this, magnifying the picture. So wherein this circulating immune complexes, the antigen antibody getting planted here, they are depositing subepithelially. Okay, so here we are seeing the antigen anti-GBM, wherein the basement membrane itself is being identified as the antigen, and then there is antibody formation to it, and then the antigen antibody reaction is happening here. Okay, then the Hayman nephritis or membranous nephropathy, wherein you find these antibodies being present subepithelial. Okay, so here we are seeing circulating immune complexes. Okay, these are the epithelial cells, the subendothelial deposits which are present here. So it's the endothelium, the visceral epithelial layer. This is the basement membrane. So these are the subendothelial deposits. Okay, and then here we are seeing the antigen antibody reaction on the glomerular basement membrane. And here we are seeing this is the epithelial layer. So the subepithelial deposition of the antigen antibody. Okay. So the mechanisms following in immune complex, what happens is that there is a, see, we have spoken about antibody type of immune response in the glomerular injury. There is another thing called a cell-mediated immune response. In the cell-mediated immune response, we got to know that there are these T cells which will accompany the antibody injury and will help in the progression of the glomerular injury and the disease. So in this way, the cell-mediated immunity is also in action in response to a glomerular injury. And the third one is activation of alternate complement pathway. Usually the alternate complement pathway is activated in dense deposit disease that will be discussed in detail when we are talking about the dense deposit disease. Okay, just remember that the immune mechanisms related to the glomerular injury are antibody mediated, cell mediated, and alternate complement pathway. In the antibody mediated, it may be in situ or it can be circulating, right? So just remember that. Now, after the immune complex formation has happened, what happens? It will attract some things called the cells, the soluble antigens. Then what happens? They'll just get accumulated and then there is progression to the disease. So we'll just see what are the cells. The platelets, the macrophages, the mesangial cells, these T cells, NK cells, all these get proliferated. The cytokines are getting into the action. So we have this oxidants, cytokines, chemokines, and protease growth factors always getting released. And then there is activation of C5A that is recruiting more of the neutrophils. And then there is cytotoxic activity which is recruiting the epithelial, endothelial, mesangial cells again. So there is complement activation and then recruitment of all these cells. Okay. So here there is a diagram. What happens? All these cells, what will they do? They form the complexes again. Here you are seeing the mesangial deposits which are seen in IgA nephropathy. And then here you are seeing this is the basement membrane. This is the endothelium. So these are subendothelial deposits. Okay. And here you are seeing the epimembranous deposits. These are the visceral epithelial cells or podocytes. In between that, this black thing represents the deposit. So this epimembranous deposits are seen in membranous nephropathy, and here you are seeing subepithelial humps that is seen in acute glomerular nephritis. Okay, so this we have spoken about mechanisms of the glomerular injury. Then we have spoken about the cells involved in the glomerular injury. Then now we just spoke about the various areas of the formation of the antigen antibody reactions or the immune complexes where they get situated, then the disease will be. So there is an immune complex formation that is getting deposited. So there is something else that is causing the glomerular injury. That is called as the injury to the podocytes. Okay. So what happens? So they usually the filtration slit. I told you the integrity is being maintained by the nephrin, podosin, CDA2B, and then actin filaments. Then this filtration slit, if it is getting damaged by an antibody, cytokine, or a toxin, there will be effacement of these food processes or the podocytes. There will be detachment of these epithelial cells. So there is an injury here. You can see the basement membrane got injured and there is no attachment to the underlying thing. So there will be plasma protein leak from here. So this can happen also add to the glomerular injury. So what is happening? The podocytopathy, there is effacement of food processes, vacuolization, retention, detachment. Okay, this can happen. Usually the podocytes cytopathy can be identified in focal segmental glomerular sclerosis and diabetic nephropathy. So these are the pictures to depict what the immunofluorescence looks like. So this is the granular immunofluorescence. You can see the granularity here. Okay. And then here you are finding immunofluorescence linear pattern. Okay. This is the characteristic of anti-glomerular basement membrane disease. Okay. So after there is an immune injury, there is something for the disease to progress, right? So the disease progresses usually in the form of focal segmental glomerular sclerosis or and tubular interstitial injury. So after there is an antibody formation, after recruitment of cells, after formation of an injury already, the progression of the disease in the kidney is being happening by two things, that is focal segmental glomerular sclerosis and tubular interstitial injury. So what is focal segmental glomerular sclerosis? I told you, focal meaning a fraction of glomeruli getting involved. Segmental, a part of glomeruli getting involved. Sclerosis, extracellular collagenous matrix deposition. So because of that, the GFR is getting reduced. So a part of the kidney is getting injured. What happens to the other ones? You know, they're all family, all the glomeruli are the family. What they do? I'm there for you. You wait. That's what the glomeruli say. The other healthy glomeruli say to the injured ones. What they do? They kind of increase in size. They kind of become a compensatory hypertrophy is a mechanism that happens in the healthy other glomeruli to compensate for the focal segmental glomerular sclerosis that is there. So because of that, what happens? Because of this, there is enlargement of this glomeruli, which are normal. And then what happens is that this GFR will be maintained in that way. So the progression of a kidney disorder related to the glomerular injury will be compensated by the other healthy glomeruli in terms of compensatory hypertrophy. So what happens overall after, how does it progress, is that there will be, if there is a problem to the renal pathology, then what happens? There can be systemic hypertension. No, the functioning of the kidney is not being, intraglomerular hypertension will be raised. So the healthy glomeruli which you are trying to compensate will have high pressure, high capillary pressure and intraglomerular hypertension. Okay, so these are the compensatory mechanisms. Then there will be epithelial endothelial injury that will cause plasma protein leak. Then the intraglomerular coagulation that will happen will lead to glomerular sclerosis. Additionally to that which is existing, then mesangial cell hyperplasia and extracellular matrix deposition happens. So finally there will be all these factors will cause a reduction in the renal mass. And the other one which I told you is a tubulointerstitial injury that is happening because of it can just be a direct effect. Okay, there can be a virus or a bacteria, for example like streptococcus infection that is just being an antigen which is just being there. There can be a direct toxicity to the tubules and the interstitium because of the reduced functioning of the glomerulus and nothing but a direct attack also can happen to the tubules and the interstitium as such. So once there is a glomerular injury, the immune mechanisms come, there will be deposits, there will be progression of this glomerular injury in form of focal segmental glomerular sclerosis and the tubular interstitial diseases. So once there is a setting of a glomerular injury, the disease progression is usually fatal. That means the reversing back is very, 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 very crucial for the patient to sustain. Okay. So this is about, in brief, about the glomerular injury, the pathogenesis, the mechanisms again regarding the immunity, the cell-mediated, antibody-mediated, and circulating, the alternate complement pathway, and then the progression of the glomerular injury, the cells that are involved. All these things, if you just learn about the glomerulus in toto, you can never go wrong in any exam regarding any question in the renal pathology, right? So this is it about the glomerular injury. We will go in detail about each glomerular disease in the next class. Thank you.